Good evening. Tonight I'm going to be discussing a patient that I encountered in my clinicals over the past week or two that was super interesting. I encountered him in the medical ICU at Baylor Scott and White Hospital in Temple. So this patient is a 23-year-old male with a past medical history that's significant for a disorder called HHT, or hereditary hemorrhagic telangiectasia, say that 10 times fast, with pulmonary AVMs and a left parietal AVM, chronic hypoxia, pan-hyperpituitarianism, very high-functioning cerebral palsy, and seizure disorder, who presented to the emergency department on November 17th when he was found unresponsive by his mother after she suspected that he had a seizure. On arrival to the ED, he was cyanotic. However, he was not in any acute respiratory distress, and he didn't have any headaches, no visual changes, no chest pain, no shortness of breath, no palpitations, no dizziness, no lightheadedness. But per the patient's mother, his baseline O2 sats usually hang around the 70s, and he's not currently on any oxygen at home due to insurance reasons. So, CT head was done, which showed cerebral hyperdensity and areas that correlated with a previously diagnosed parietal AVM. CT of this chest was negative for pulmonary embolism, but it did show a similar appearance of multiple bilateral pulmonary AVMs that he had had before, because he had recently had, over the summer, had some of his pulmonary AVMs embolized. So he was given some Keppra, and he was then admitted to the unit for further monitoring. He had an EEG done, and it did not capture any acute epileptic seizures. So as I had mentioned, he was admitted the past summer. He had an echo study done with a bubble that showed a large intrapulmonary shunt. So he had IR embolization of right lower lobe and left lower lobe AVMs back in June, like I mentioned. During his admission, he was having a lot more desatting episodes, and he had an increase in O2 requirements. So he had another echo with a bubble study done, and it showed another very large intrapulmonary shunt. So he was taken again during this admission to IR for embolization of 3 pulmonary AVMs in the right lower lobe on November 25th. So he had been kind of bouncing back and forth between the med-surg floor and the medical ICU because of seizures and desatting episodes. And at the moment that I saw him, like I mentioned, he was in the MICU, and he was actually being evaluated at Methodist Hospital in Houston for a possible right lung transplant. So this patient was very interesting because, of course, I'd never really heard of this disorder. It's very, very interesting. So HHT is a pretty significant vascular disorder that's inherited as an autosomal dominant trait disorder, and the most common clinical manifestations are nosebleeds. That's typically how patients are initially diagnosed, is that they have these like crazy unexplainable nosebleeds, or they have GI bleeds, iron deficiency anemia, or AVMs, like in the case of this kiddo. So the prevalence of this disorder is between 1 in 5,000 and 1 in 8,000. So kind of a rare thing, but it's really an interesting type of disorder because, you know, in addition to him actually just having these issues, the pulmonary AVMs, of course, were leading to chronic hypoxia. So, of course, he then developed some issues with his, his hematology. He had polycythemia, which was secondary to the chronic hypoxia from his AVMs. So we were making sure that we had him on heparin for DVT prophylaxis, since he was pretty high risk for that. Then, add on to all that, he also had that pan-hypopituitarianism. So reading about that, didn't really know very much about the treatment of that either. So the 3 mainstay treatments for that disorder, or you want to make sure you're addressing an ACTH deficiency, of course, CSH deficiency, and gonadotropin deficiency for this. So for this kiddo, we were giving him hydrocortisone for the ACTH deficiency, Synthroid for the TSH deficiency, and typically he would be getting testosterone injections monthly on an outpatient basis. But interestingly enough, in the hospital, they tend to hold any type of testosterone or estrogen replacement therapies because it can actually increase the risk for DVTs to form in an acute setting. So just a really interesting case. Gave me a lot to read about and learn. And what ultimately ended up happening to this kiddo is that he was actually, insurance denied him being able to be transferred to Methodist for his lung transplant. So he's still just kind of hanging out in the hospital waiting to see what's going to happen, because typically with this disorder, these AVMs are common. So, he's going to always keep having these issues. So that's kind of the ultimate goal for him would be to get the transplant. So hopefully he'll be able to get that. Sorry, I'm really tired making this video. So hope it gave some good information. This was a really cool case, a lot for me to learn from. So thanks.